All right. So as Eva said, this is the part two, no, of a three-part lecture. So basically, we just repeat some of the slides, no, because some may have missed this last time. So the objectives of this lecture is to provide you pointers on how to diagnose and manage common diseases of the eyelid, conjunctiva, cornea, and ocular surface remotely by means of teleophthalmology, and to inform you on what external eye disease conditions that might require a face-to-face consultation. So there are limitations to teleophthalmology. The most obvious is the absence of a slit lamp, that you do not get a magnified view and a very, very clear image of the details of the anterior segment of the eye. There is some that you can't do have an upper palpebral conjunctival examination, no, unless the patients can do it themselves. You can check the eye pressure or check intraocular lesions and do other ancillary tests like corneal sensations, staining, and even tear breakup time. So, but these should not hinder us, no, for being able to get to the as closest or as accurate as a diagnosis as we can, no, based on the information the patient gives us and based on the views that we can have, no, through pictures or through videos. So part one was a month ago. Now we talk about blepharitis, MGD, or jolum, dry eye disease, and herpes zoster ophthalmicus. Today is part two. We'll talk about infectious conjunctivitis, the whole gamut of allergic conjunctivitis, and lesions on the conjunctiva like your ACG, your pinguecula, and we'll touch a little bit on nodular scleritis. And next month we'll have part three that will be on keratitis, pigmentosis, and basically diseases, infectious and inflammatory diseases of the cornea. Okay, so the conjunctiva. So I'm sure all of you might have gotten calls or have video teleconsult for this problem. So adenoviral conjunctivitis. It's something I believe that you can really diagnose almost accurately over using teleophthalmology. Of course, the history is very characteristics, acute in onset. Okay, you have symptom by redness, and then there is it can involve with one eye, and a few days later involving the other eye, and particularly important is a history of exposure, to either people at home, people in the neighborhood. Okay, so I maybe with all this quarantine going on and social distancing and all this hand washing, I believe actually there should be actually the decrease in the incidence of adenoviral conjunctivitis, so at least the spread of adenoviral conjunctivitis, because similar to COVID, it's very, very infectious. If COVID is spread through the airborne droplets from the nose and from the mouth, of adenoviral conjunctivitis spread to the tears and discharge. So as I always say, to be able to diagnose conjunctivitis, you should at least fulfill two things. The eye should be red, there should be redness, and there should be discharge. Of course, there are several types of discharge. In redness without any discharge, you might actually doubt the diagnosis of conjunctivitis. Okay, so here we have a patient bilateral involvement, with red eyes and watery discharge, because at the first few days it's a bit watery, and by the 5 or 7 days it becomes mucopurulent. So the type of discharge is really dependent on at what point in time you see the patient. So there should be diffuse redness not only on the bulbar conjunctiva but also as the palpebral conjunctiva as well. Patient can give you this kind of picture, kaya naman ng phone to at least capture this image, and then you should seek congestion in the entire conjunctiva. Now, this will be a bit more difficult. I don't think you can have a good shot or a more detailed picture of follicles, especially in the inferior conjunctiva. Harder will be to flip the upper lid to see the papillae. So basically, your main basis will be history, and then the presence of redness and the type of discharge. Here you can, subconjunctival hemorrhage, it will be quite helpful if you see patches of redness, and patients can actually describe this. So, and I'm sure we also have got a lot of teleconsult for subconjunctival hemorrhage. So this is something that they can take a picture of and something you can see. And if on top of eye redness and discharge, acute onset, and all the symptoms, you see patches of hemorrhages. Again, they can point out to an adenoviral conjunctivitis. What's difficult will be the conjunctival membranes. No? So this will actually, when you see this, you should actually ask the patient to come in. This will need a face-to-face consult, no? Because you cannot just let it be. You really have to physically strip the membranes. And you can get this sign by asking the patient if there's bleeding. If the patient says when they rub their eyes and then there's blood, probably you have disrupted conjunctival membranes causing the bleeding. And this is a sign that's a more severe case that needs actual consult. So in the basic treatment, we know that avoidance is still the best treatment. Okay, I mentioned earlier, we are we're all practicing social distancing. So of course, it's still limiting. Even if you don't give anything, you can just advise the patient, assure the patient that it will run its course. You can give supportive therapy. If you're not 100% sure, you can just, decongestant will be safe for a short course, and cold compresses to relieve them of symptoms. Now, if you do see membranes and you are 100% sure of your diagnosis and that the patient is reliable, then you might want to give some steroids. Okay, it is a very severely inflamed eye. But again, you have to prescribe this with caution, okay, to avoid the complications of long-term corticosteroid use. And membranes, you have to see them and remove them as often as needed. At the minimum, if you can, nowadays every day might be a bit difficult. Maybe at least every 2 days, they have to come in and have those membranes stripped. Okay, so then sometimes, so one of the sequelae of your adenoviral conjunctivitis will be your EKC, when you have the antigen-antibody reaction on the cornea. So this usually occurs after the resolution of your conjunctivitis. And a patient would come into you complaining of photophobia, foreign body sensation, okay, and the blurring of vision. The blurring actually will depend on the location and on the amount of lesions that you have on your cornea. In these two pictures now, and you will see there is central involvement. So patients will really complain of blurring of vision. These are other views. So usually in a higher magnified view, an EKC is actually an SPK, a superficial punctate keratitis. You actually see this granularity with an apex. So when you stain it with the fluorescein, the tip, okay, will stain. Okay, and this is a cross slit lamp view showing you it's very superficial location. This is a higher magnification showing you on the left. This is acute. This is in the early phase, and after a few days, it would go deeper, and give you this granularity. Okay, when you stain this, it won't stain anymore. Okay, and but it will give this at this when you have deep staining, they will have foreign body sensation, and once it doesn't stain anymore, they will complain more of the blurring of vision. So they occur 10 to 14 days, and then it occurs around in 1/4 of patients who had adenoviral conjunctivitis. You don't expect it in all patients. So I only treat only when it's symptomatic. Okay, basically disabling photophobia or glare and decreased vision. The patients absolutely would need a good vision to do their job or to drive safely. Then you are forced to give. Because actually the best is actually to let it run its course. Because once you give steroids, then you're tied down to it for a while. Because you have to taper, and then once you stop, it will come back, it will recur, and then you have to repeat the cycle all over again. So, but when you don't treat, let it run its course, usually in a few months, all the lesions will resolve. Okay, so for me, treat only when totally needed, and only give really very mild steroid. You don't need strong steroids here, no, or full dose, your fluorometholone, your loteprednol, no, or your 1/4% prednisolone acetate, no, will be good options, no, to treat your EKC. Okay, so we're done with the adenoviral conjunctivitis, and let's proceed to another type of infectious conjunctivitis, and this is your chlamydial inclusion conjunctivitis, the most common cause of chronic follicular conjunctivitis in adults, and the most common cause of ophthalmia neonatal. Okay, so it's actually, I was thinking about this, no, and actually it would be, if there is a way, no, to check the incidence of inclusion, no, probably in this, for the last 6 months of lockdown, no, I'm sure there are less of inclusion conjunctivitis, no. Okay, so meron namang silver lining. So for a newborn, okay, in a neonate, no, so patients will be symptomatic usually after the 5th day of life. No, you do not the patients, a mother will not complain or will not report any abnormality till after the 5th day. No, 5th day or a week after birth, the mother will complain there is discharge, no, or solid swelling, okay, and then when they try to pry open the eye, no, it might bleed like this, no, because it forms membrane, and actually they become alarmed. The parents will become alarmed, and they will say that the eyes are bleeding, no? So this might actually be the chief complaint when they consult, no? So it's very important, again, the timing, no purulent or mucopurulent discharge here, okay, nothing yellow, okay, mostly the eyes red, and there is some bleeding. So if you see this after 5th day, after a week from birth, then and it should be a vaginal delivery, then probably this chlamydial ophthalmia neonatorum. In adult, it can be in neonate usually it's bilateral. Okay, in adult it can be unilateral. It can also be bilateral, but usually it's unilateral. And it's a chronic conjunctivitis. No, it's unlike your adenoviral, no, which usually resolve by 2 weeks time. In chlamydial inclusion conjunctivitis in adults, no, actually it will peak after 2 weeks. No, so parang ang tagal, sabihin ng pasyente, Doc, kasi parang ang sore eyes yung ang tagal-tagal, hindi pa rin nawawala, no? So 2 weeks, 3 weeks, then you might see them, they will send a picture, eye redness, there is pseudotosis, no? So then of course the history is very important, no? In a sexually active adult, that should be asked, no? So if you have that and you see this, then you're almost sure of your diagnosis. Okay, so very particular, no? So it's the follicles. It's a chronic follicular conjunctivitis. So you may not again see this unless you do a slit lamp, or if they have a macro camera attachment for their camera, maybe you will be able to see the very obvious follicles. Now, when you flip the upper lid, also aside from the papillae, you see these round white lesions. These are also follicles. No? So the follicles are very prominent in chlamydial conjunctivitis. Okay, if you don't see the follicles, no, they also have this very dense papillae, no, so it's almost what we call velvety. No? It becomes like a carpet. Okay, all the papillae. Some patients can have limbal swelling like this. No, you have examined the limbus. It's a bit elevated. No, so when you put the fluorescein dye, will actually give you a negative stain. No, because this area is elevated. And then we also have signs of micropanus, no, of small vessels growing into the cornea. So very rarely, you see peripheral infiltrates. No, okay, it's not very common. You don't need to see that to make a diagnosis. Okay, so basically the history is very important. No, for neonate conjunctivitis with blood, with bleeding, usually after 5 days of life. In an adult, no, redness and minimal discharge, no, and sexually active history with its course of more than 2 weeks, no, that's probably it's chlamydia. So in an infant, you treat, you give your topical erythromycin, okay, or they give them systemic or erythromycin at 50 mkd in 2/4 divided doses for 2 weeks. Okay, Now, for the parent, now you have for nurse, if the mother is nursing, then you have to give erythromycin also to the mother, or you can also give your azithromycin. No? That's another option. And treat the partner. For adults, no, can give topical moxifloxacin. We don't have topical, it's fine. And actually, the systemic is more important. Nowadays, no, we just give the oral azithromycin at 1 gram single dose. It's much simpler. Okay, the compliance is quite high, no, because if you give your tetracycline, doxycycline, or erythromycin, you have to give it for 3 weeks. Oral azithromycin is only 1 gram single dose, and also treat all the partners of the patient can think of. So may contact tracing then, no, for chlamydia. No? So the patient had to do that. Okay, and then treat all of them. Okay, so that is your chlamydia. Now we go to another condition. Patients coming into you with acute redness with copious purulent discharge. No? As Dr. Valentin would say, sa pintuan pa lang, hindi pa papapasok ng clinic, magtingin mo lang sa pasyente, alam mo na yung diagnosis. No? And that is one of those, no? Your gonococcal or gonorrheal conjunctivitis. No? Mind you, streptococcal conjunctivitis can also give you very similar findings. No? So don't be judgmental, no? So pwedeng strep. Okay. So this is a patient way back, no? In my fellowship, no? He's a 78-year-old white male complaining of bilateral copious redness with purulent discharge. Okay. So siyempre, I think isip ko, wow, probably it's gonococcal, right? Okay. No, it's not, no? So it actually turned out to be strep. Okay. So typically, this is what you would see, no, in an adult with gonococcal conjunctivitis, no, with really the purulent discharge really literally dripping out of the eye, no, and the redness. Okay, so really gonococcal will be your primary diagnosis here, no, when you see this, no? So actually patient can send you a picture, tell them not to wipe their eyes, not to send picture as is. Okay. So here also, no, you don't need a slit lamp, no? So again, there is diffuse congestion of the conjunctiva with chemosis, no? And a very prominent discharge, no, purulent discharge. In a neonate, no, the symptoms usually is less than 5 days from birth, no? So then you have purulent discharge in a newborn, less than 5 days of life. Then, again, you're almost sure that you're seeing a case of gonococcal ophthalmia neonatorum. Now, the problem with gonococcal, you have to treat really fast, no? Especially you have to treat them as soon as possible. No, usually you have to see them treat them as within the first week from the onset of symptoms. Because if they last longer, more than a week, up to 2 weeks, then that's a time when you will see all these corneal complications. No? So if it starts out with a diffuse haze, then you get the defect, then you get a marginal infiltrates, then you can get an actual marginal ulceration, then corneal melt and rupture. Then when they heal, you develop scarring, no, and you can develop a focal staphyloma in those areas. Okay, so severe chemosis, no, very severe. Okay, the worst chemosis you can see, you see that in gonorrheal conjunctivitis. Okay, here you start to have corneal epidefects and infiltrates now here. Okay, you have haze now here. No? There's already cornea beginning corneal involvement. Okay, this is another picture of the same eye. Okay, showing you the marginal corneal ulcer here. And now here is the worsening. Now there's corneal haze and edema, and there is expansion, no, of the marginal ulceration. Again, in an eye with severe chemosis with purulent discharge. So usually the rupture is in the affectations on the cornea is usually superior, and then it will cause peripheral thinning and rupture and foveal or iris prolapse. No, if you see this, you're sure that the condition has been at least 2 weeks. No, hindi yan mangyayari during the first week. Okay. Okay, so this is peripheral rupture. This is now a diffuse corneal melt, no? Okay, so almost the entire cornea is involved and it's infiltrated and it's now melting. Okay, and this is just a remnant, no? You don't even see a semblance of a cornea anymore. And here, ito na lang, no? So, wala na, no? Ubus na yung cornea. No? This is partially treated already, no? So that's why you don't see a lot of the purulent discharge anymore. So how do you treat? Okay, so I think diagnosis won't be too hard, okay, based on history and a picture and a characteristic findings. Now you can do this through a teleophthalmology. Of course, you cannot do a gram stain and look and confirm it with your do a conjunctival swab and do a gram stain, no, to see the gram negative diplococci. Okay, but I think the history and the clinical signs are adequate, no, to make a presumptive diagnosis. So you have to irrigate conjunctiva terminal discharge. Patient can do this. Can ask them to buy distilled water. No, they can wash their eyes. No, distilled water. Now they really have to come in. No, they have to come in. Now they cannot do this themselves. No, they have to come in. For neonate, no, by weight. No, usually we also give ceftriaxone. Adult, no, it's 1 gram. No, for adults we give 1 gram injections. No, IM. For neonate, no, less. Or you can give IV. No, that's also another option in patients with severe affectations, no, with rupture or bilateral involvement with corneal melt. Maybe you want to admit them and give IV ceftriaxone. Your other options, in case you're allergic to ceftriaxone, then you can give your ofloxacin or ciprofloxacin orally, 500 milligrams for 5 days. Topical, you can give a lot of this, the fluoroquinolones, so not a problem. And at the same time, don't forget, a lot of these patients will have concomitant chlamydial infection. So aside from giving your ceftriaxone, make sure you also give them your azithromycin 1 gram to treat the chlamydia. So this is a case wherein after treating the gonococcal, we notice how come the eye is still red, and when we examine closely, you still see these very prominent follicles, so this is because you have not treated the concomitant chlamydial infection. So that's why it should almost be standard as SOP. Now, what happens when you have your rupture? So some of these are some of your options. You can do a flap to cover the hole, or you can have in a larger hole, a larger rupture. Then you can do an eccentric penetrating keratoplasty, or an even oversized keratoplasty, or a marginal annular PK or lamellar keratoplasty. If you do that if there's for the peripheral melt. So this is an advancing conjunctival flap. Patient had a small rupture superiorly, so we got bulbar conjunctiva from the top, and we just slid it over. Okay, cut this, undermine, do alperitomy, move it forward, and suture it tightly, to cover the area of rupture. This is an eccentric penetrating keratoplasty. The rupture is inferior. Okay, it's too big to do a flap. Okay, so we just do an eccentric graft. This is an annular keratoplasty. If your conjunctival flap may not work, again, you have to fashion from a peripheral donor cornea, from the donor cornea using the periphery. Actually using the rim of their corneal button, you can fashion it into an annular graft to cover that area. So underneath the cornea, you can see the area of rupture. This is an area of thinning. Okay. Once in a while, now you might see these patients, okay, a child or even an adult, showing you superior scarring, okay, like this, okay. So it's really because patient, when you ask the history, of course the child will not know, but if you ask the parents, they would actually, you can ask them if patient had a history of severe redness and discharge during their first week of life. The answer is yes. And most probably patient had gonococcal conjunctivitis with corneal involvement, which eventually healed, or when they were treated, when they get treated and they heal, it forms a scar. This is an adult patient, no? Okay, coming to you with large, thin-walled bleb, no? Okay. If you see this, no, your first impulse is is a glaucoma patient who had a trab, no, with mitomycin. However, patient had never had any form of surgery. But patient had history of eye redness when he was young. Okay, out of discharge. So it actually spontaneous healing. There is rupture and there's advancement of the conjunctiva. Okay, and then actually it forms now an unguarded bleb, filter, no, and it forms a bleb. So this is due to gonococcal sequelae. No? So bihira naman. No? So just trying to show this because it's quite an interesting picture. Okay, so so we've covered that is the most common type of infectious conjunctivitis. Of course, there will be your staphylococcal conjunctivitis, streptococcal conjunctivitis, moraxella conjunctivitis. Those are the other bacterial conjunctivitis you have to think about. No? So in streptococcal, no, again, usually patients don't really get strep conjunctivitis very often unless patient has an history of nasolacrimal duct obstruction. Now, if they do and they get recurrent eye redness, then you think of strep. For moraxella, it is in a younger patient, no, and usually they should have signs of angle macerations. Now, angle macerations with eye redness and discharge, and that will be your moraxella. For hemophilus conjunctivitis, usually that is in a child, no, less than 10 years old, complaining of bilateral redness with mucopurulent discharge, no, on top of the signs of an orty. No? So if you have orty, eye redness, matting of the lashes, then you think of hemophilus conjunctivitis. For staph, okay, usually occurs together with the chronic staph bleb. No? In a staph blepharitis with eye redness and discharge, and most probably that's staph conjunctivitis. Okay, so now we go to the allergic conjunctivitis. Okay. So in the cardinal sign, no? So if the for infectious conjunctivitis, redness and discharge, now here is redness and itching. Now the itching should be very prominent. Okay, so you have several types. No, we'll talk about your simple or your seasonal. You can actually divide it acute hay fever, seasonal, but with now it's simpler just to say your simple allergic conjunctivitis or chronic allergic conjunctivitis. Another separate group is your vernal keratoconjunctivitis. Okay, you cannot lump this together with your simple or chronic allergic because it's totally different in some ways. Atopic KC, no, but very common. No? We don't see much of that here. GPC is usually secondary to an offending agent. Okay, contact dermatitis medicamentosa, again, it's also usually to an offending agent. So in an allergy, no, you do get some discharge also, but it's stringy and it's not pure, it's not prominent. No? It's usually redness and discharge. No? And the history is there is recurrence. No? It's patient has atopy, patient has asthma, patient has urticaria, patient has eczema. No? So there's all the signs of atopy, no, in other parts of the body. No? And they usually, there is a pattern, exposure to dust, or there's due to season. Then they get more symptoms. No? So it's not really that hard to make a diagnosis of allergy, no, from the history alone. Eye redness, recurrent, episodic, and with itching. No? So that's your allergic conjunctivitis. In your simple or your perennial, no, ito yung, it's a little bit and it goes away and it comes back. Okay, so very mild, very little findings, no, except for, again, signs of chronicity. The patient had this for a long time will be the pigmentation. No? So when you see pigmentations like this, matagal na yan, no? Pasumpong-sumpong lang yan. And when you look at the conjunctiva, it's not as pristine as a normal conjunctiva. No? It's a little bit wet, a little bit, what we call a bit boggy. No? You don't really see follicles, no? Maybe a little bit of papillae. So it's a pinkish red type of redness, not as red as in your infectious conjunctivitis. Of course, VKC, the profile, no, is almost characteristic, no, prepubertal male, no, usually 3 out of no, out of 90 75% will be male. Okay, so if you then flip the upper lid, well and good. No, if they come in and you see them, you flip the upper lid, and that's it. You can't. That's this almost the most classic signs of your vernal keratoconjunctivitis. Of course, now it can also appear as limbal vernal. Okay, more with the papillae more prominent at the limbal area. VKC, now you can also look for horner strantas dots, which you may not see using through a teleophthalmology, no, but you don't need that, no, to make a diagnosis. Poor vision, okay, foreign body sensation, itching, no, you see loss of luster, no, when they take a picture of that with the flash or with the light, no, and you don't see a sharp reflection, then most probably that's the surface. There's epitheliopathy, no, because of the poor or damaged surface of the epithelium. Okay, so that will be your clue in a picture. No, when the reflection is not sharp, okay, you have lost the normal luster of the cornea, then something is wrong with the surface epithelium of the cornea. Okay, pigmentation, I mentioned that. You also see that in VKC. You have this pigment migration to the chronicity. In allergic dermatoconjunctivitis, okay, we have eczema on the lids, on the skin of the lids, no, and you see papillae on both the bulbar and palpebral conjunctiva. Okay, so in the treatment of allergy, avoidance of allergen is still the best form. Okay, really you have to make sure you avoid what you're allergic to. No? But if you're allergic to pollution, no, and then or to pollen or to dust and those things, no, some it's very difficult to avoid. Okay, so in severe cases, no, like in vernal keratoconjunctivitis or atopic keratoconjunctivitis, you might want to partner with allergologists, no, because this in a way because it's harder to treat these cases, no, and they can be very severe, and you need more potent medications now to be able to control this disease. So what are the principles for therapy for allergic conjunctivitis? No, so it should be based on a case-to-case basis. There aims to control symptoms and prevent complications with the least amount of medications. No, you do not give them too much, okay? Because again, you have to think about toxicity and compliance and the costs. You can start with medications that are less toxic or potent if the allergy is quite mild. No, you don't have to give strong steroids immediately. Okay, explain to the patient that the chronicity of the problem, no, that this is something that can recur because it's really how they are built. No, it's really in their genes. No, and this can be passed on, or they can acquire this. Or this is acquired from my heredity. And always try to identify the allergen, no, so they can avoid it. So treatment, okay. Nowadays, no, the standard of care, no. So this is just basic historical, no, basic antihistamines. I don't give those. Wala ni antihistamine, levocabastine, pure mast cells. Well, it might not be useful because it takes a month for it to start working. Nowadays, it's really giving an antihistamine mast cell stabilizer immediately, no, because you want to control the symptoms. Give antihistamine immediately so that it stops the symptoms, and then you give a mast cell stabilizer to prevent further or future recurrence of the problem. Okay. So sometimes we really have to give steroids, no, if the antihistamine and mast cell stabilizer doesn't work, or just can't totally eradicate the symptoms, then steroids will work. Okay, but it's very effective. Okay, but it's not always safe, no, because the downside, your patients might use it on their own and then not knowing of the side effects of steroids. Okay, so what are the guidelines? No, if you choose an ester steroids, no, like loteprednol, to lessen the chances of cataract formation and increased IOP. Or you can start with weak steroids or half concentration if the patient's condition is mild. Okay. Now, if this very severe case, moderate severe, then you have to give a higher concentration of steroids, no, you titrate accordingly. Then you cut back, no, on the frequency when symptoms subsides, no, and try to maintain of steroid sparing drops, okay, and then which will be include your antihistamines and your muscle stabilizers. Then you make them use steroids only for pulse therapy, no, because depending on the amount of allergen, no, that they are exposed to, sometimes it gets very severe. Then that's a time when they have to use steroids, no, and then just tell them to use it for a day. No, once the symptoms is gone, then they should stop immediately. No? So pulse therapy lang. Okay. So well, steroids naman. No? In these cases, you don't have to do tapering. Okay. Then you have, if they can, have to advise them to follow up regularly, especially the children. Okay, especially if they're on steroids. No, and never forget to educate them on steroids. For patients with severe VKC or patients in AKC, which are contraindicated to steroids, or they are steroid responders, no, then you can give your topical cyclosporine. You have 0.5%, you have your 1% to 2%. No? So these are your options. It should be higher. No? The 0.05 will not really work. Okay, you should be at least 0.5 and up. Okay. So in VKC, the cornea usually involve, okay, you get punctate keratitis, shield ulcers, and then you let them be, they become scars, no? And they are also corneal vascularization. That's why VKC is a blinding disease. No? It can cause corneal blindness, no? If not treated adequately. It can, no? Usually in normal times, no, we give, in children, in severe cases, we give supratarsal triamcinolone, because it really works, no, and it's a depot. It can, the eye improves very rapidly, no, and even if they forget using the drops, they can. The medicine is always there. Okay. So if you see a shield ulcer, if you suspect a shield ulcer, patient has to be seen. They have to come in. Okay, these are dangerous. These are severe signs. So they have to be seen, because you might have to put a bandage contact lens. You might have to, again, debride the area, for it to heal nicely. And then systemic, don't forget, giving systemic antihistamine is always an option. So these are some pictures. This is a case of vernal, limbal vernal. No, show this is before treatment on the left. Okay, and this is after treatment on the right. No, okay. So yeah, there is, you just have a residual scar of the limbal area. But again, what I want to show you is the luster, the reflection. Okay, here there's a problem. Look at the reflection here. It's sharper. No, it means that the corneal has healed. The corneal surface has healed. This is the other of the patient, just showing you the same thing. So GPC, okay, it might be a bit difficult for teleophthalmology unless they're able to flip the upper lid, because usually the lesions are in the upper palpebral conjunctiva, because the causes are usually on the ocular surface, just like your soft contact lenses, exposed suture, okay, prostheses, ocular prostheses, etc. No. Okay, so it's very important. No? So if you suspect it's a GPC, they have to come in, no? Because if you really have to check them, you have to make them stop using the contact lens. They might have to change their prosthesis, or you have to remove a suture. Okay, so we usually start them on antihistamine muscle stabilizers, or even mild steroids, no, until those lesions subside. Now, even if you don't give anything, no, as long as you remove the offending agent, no, usually in time, no, the problem will heal, will resolve. Okay. For soft contact lens wearer, it's usually a problem, because sometimes even if they do contact lens holiday for a month or so, after treating, everything's nice and clear, and then when you resume contact lens, no, it will recur. Okay, so it's a bit difficult. You can shift them to RGP if possible. Okay, if not, they just do daily replacement. Okay, or they have to really shorten their wearing time, or just where it only when it's really needed. Okay, so it sometimes can be it can recur very quickly in some patients. Okay, the soft, especially the contact lens wearer. Okay, this is your contact dermatoconjunctivitis. Okay, this is usually we get this on patients on chronic drops. No, usually are glaucoma patients who are on chronic medications, on multiple medications. No, and patient will complain of lid swelling. It's a weepy lesion, no, this, and very itchy. Tapos masakit, no. Okay, because this very raw. Okay, there is loss of epithelium, no, and it's quite painful and itching at the same time, no. So this I'm sure can be again based on the history of drops, no. You can ask for what the patient's using, and then with this picture, now which you can actually see grossly, then you can make a diagnosis of medicamentosa. So it's usually due to the preservatives of the drops, or it can also be due to the active ingredients. So the most important is first to stop all medications, no, let it heal, no, put them on cold compress. Okay, you might use preservative-free saline solution for washing. I always give them systemic oral, no, antihistamine and steroids, so that the symptoms that the problem will resolve much faster. Okay, so once everything is okay, then you slowly resume back. No, let's say it's a glaucoma patient. Make sure you try to shift everything to preservative-free and add the medications one by one. No, because if you start at 2 or 3, you will not even know which one is causing the problem. Okay, there. Okay, so there. No, so we're done with the allergy, and now we're in our the last part of the lecture for today. Okay, so it's now we're talking about ACG versus pinguecula versus nodular scleritis. So, well, usually the problem is they all look alike. Okay, so ano ba talaga? No? Okay, so first, no, risk factor. Okay, so this will help you in the history. In an ACG, usually young female. Okay, pinguecula, usually you don't see them in children. No, again, you really need chronic UV exposure to develop a pinguecula. And nodular scleritis, no, they have autoimmune diseases or tuberculosis. Here, tuberculosis is very important to ask. No, you always have to ask if you have TB. Okay, in chief complaint of an ACG, you have a mass and a redness. In pinguecula, there might be occasional on and off redness and irritation. ACG will not give you pain. No? Patients will come in only because if there's a very prominent red spot, a red area with an elevated area. In nodular scleritis, there is redness and pain. Okay, so this will differentiate one from the other. So ACG pinguecula will be located at the exposed bulbar conjunctiva, while nodular scleritis can be anywhere on the bulbar, on the eyeball itself, the anterior eyeball. At least we're talking about anterior nodular scleritis. So this is an ACG is a conjunctival granuloma. Pinguecula is due to an elastoid degeneration. Nodular scleritis is due to scleral edema. Okay, since they are ACG and pinguecula are located on the conjunctiva, they are both mobile. Okay, while the nodular scleritis is not mobile. Okay, so putting the 3 pictures side by side, no, because here basically on the same area. Okay, so this is an elevated lesion. This is an ACG. This is an elastoid degeneration. Okay, surrounded by a focal inflammation and congestion. And here is the focal nodular scleritis. Okay, hindi naman actually sila pare-pareho. No? So similar, but not quite. Okay. So for actinic conjunctival granuloma, no, there is a granuloma that's inflammation centered around areas of elastoid degeneration in the conjunctival substantia propria. That is the histopathological findings. No, 90% female, no, very common, young female with a mean age of 25. No, this is based on the publications of Dr. Valenton. Okay, it appears as clusters of 3 to 4 nodules. Okay, pinkish yellow around can be as wide as 4 millimeter. The whole lesion can be 4 millimeter in diameter, surrounded by vascular congestion. Very important, no? Very prominent ang vascular congestion. Can also be associated with pinguecula. No? Okay? So usually, again, raised nodular. No? Hindi siya smooth. No? Usually, parang grape, bunch of grapes. Okay? So, or sago-like. No? A clump of it. Okay, right there. Okay? Pwede maliit lang, pwede malaki. Okay? Pwedeng ganyan, malaki-laki. Again, the commonality will be the severe. No, it's always vascular congestion or is present, no, around it. Okay, again, this is multiple nodules raised and always at the bulbar, exposed bulbar conjunctiva, the interpalpebral area. Okay, the palpebral fissure area. Now, pinguecula, no, is a degenerative lesion and elastosis of the bulbar conjunctiva secondary to UV light. Okay. And UVC cause pinguecula? I don't know. Well, the cornea will suffer first. Again, in the interpalpebral zone, usually nasal, no, you see a yellow-white amorphous subepithelial deposit. It enlarges over time. No? And then because it's elevated, and because of the constant friction of the lids, no, the lid wiper on the lesion, it can give you on and off irritation that it'll become inflamed. No? It's because of the constant rubbing. Okay, so here you go. No? So this is inflamed. No? So it's a bit elevated, and then you have surrounding redness. Here, hindi na, not much redness. No? This is not an inflamed. This is not an inflamed. So it's not a pingueculitis. No? So when it's inflamed, it's a pingueculitis. When it's not inflamed, no, it's just a pinguecula. Okay, so this is just showing you the pinguecula delent pterygium model, no? Showing you the a raised lesion. This is your pinguecula that has advanced to the limbal area, causing you a delent. No? So this is elevated. So there is a divot here, or a valley, no, causing poor wetting. The poor wetting causes a delent. Okay. Then what happens is, because of the drying here, this conjunctiva now will move forward to cover this dry spot. However, then beyond the tip, it will form another delent. No? So kung nag-delent uli, then it will again move forward to cover that dry spot. So this is one of the theories of progression of pterygium, no, that arises, that arose from a pinguecula. No? So this is your pinguecula delent pterygium theory. Okay, and lastly will be your nodular scleritis. Okay, it's part of the anterior scleral spectrum. You have diffuse nodular necrotizing. You see a deep red to purple immobile nodule. Okay, it's deep violaceous. It's violaceous in color. Then it's surrounded by inflamed sclera, violaceous sclera, no? Because it's really on the problem is on the sclera itself, not on the conjunctiva. So it may be associated with the scleral abscess, no? And there is pain and tenderness at that area. Okay, so this is some pictures of nodular scleritis. Okay, you see this elevated lesion, no? It's violaceous hue of the sclera. And here you have actual abscess formation. No? So there is usually there is necrosis na of the tissue itself, no, causing this yellowish lesion. So let's go to management. No? So for it's an ACG, no, steroid is the mainstay of therapy. No? Walang ibang, only steroid will work. No? You have to give it 4 to 6 times a day for 2 to 4 weeks. No? When you give topical, it will not go away in 1 week. No? Usually 2 to 4 weeks. Okay, so that's why you have to monitor their pressure. They might have pressure spike after 2 weeks. If you want it to go away faster, no, you give sublesional or paralesional triamcinolone. Usually, you give it today, after 2 days, wala na. No? So it's now nice and flat. Okay, so in less than a week. So just give very little 0.1 lang. You don't give a big amount. For pinguecula, no, usually It's a chronic problem. No, it's usually due to poor lubrication. No, so you can give decongestant or lubricant on a as needed basis. If there's severe, there is moderate to severe irritation, you can give them steroids, not just for a few days, not just 3 to 5 days, and tell them to stop. Okay, so rarely, no, you have to excise it. You have to excise the pinguecula. And for nodular scleritis, again, steroids is the mainstay of therapy. You give it high, no, president acetate 8 times a day, 2 to 4 weeks, no, and taper slowly over time. No? And of course, you have to look for the underlying cause. You may give subconjunctival triamcinolone as long as patient has no active tuberculosis. Other options will be topical NSAID. Usually, they don't really work quite well. No, you just steroids still the mainstay. Okay, oops. Okay, so if topical, they don't respond, then you have to give oral steroids. No? Okay, and again, don't forget to look for the underlying cause when you're treating nodular scleritis. Okay, so these are just some of the pictures. A nodular scleritis before and after treatment. So this is an active nodular scleritis with focal triamcinolone injection. This has healed another patient, not exactly the same patient. Okay. I know it's the same patient, baliktad lang yung picture. This is showing you the thinning out na, no? Because there's loss of scleral collagen, no? So there's thinning of the sclera, showing you the underlying choroid. No? Okay, so I think that is the end of my part 2. So the floor is now open to questions.